we're talking about upping our game. I gave it that slogan. I probably is a little over the top slogan, but I think that's what the goal is in the long run for all of us, but especially with this, what we're going to talk about today, the project involved. And just this week, just to do an update, as you know, across the country and across the world, things are starting to happen with COVID ahead of schedule, I should say, right? In some cases, people are surprised at the rise, but it is almost October. And last week, and by the way, I've said this last week, I want to just repeat, from now on, what happens is we have a situation where the state is publishing Wednesday reports. So on Thursdays, we get the report for the previous week, whereas I was getting daily reports for a while. So we've gone from Friday to Friday to Wednesday to Wednesday. And the cases rose 2,700. And that 1,558 is from 2 weeks ago, it was about 2,000 last week. So that's sort of, you know, that's not great because that's obviously a higher number. And although deaths are down, the higher number means we don't know what's going to happen, right? As the numbers go up for the objective number of deaths. And so it's still 99 people passed away. That's still nothing to get excited about. It's sad, and we need to keep an eye on this. For congregate homes, the last data I could get, I could not see the data for 9/23. 5 in state operated homes out of 1,048 people, and there are 12 in private provider homes that have the virus out of 7,885 people. So it's not a huge thing yet in the homes across the state, FYI. But it's, again, something for us to be aware of. And again, that's the topic today is very relevant, you know, to what we're seeing happen. And so the key issues in advocacy, really quickly to remind you, we continue to have equity in healthcare is right up there as an issue. And I'm excited to say that Tufts Healthcare Foundation provided us with funding to expand our healthcare triage outreach to medical settings. They actually gave us $20,000. We're expecting less than that. And we're really thrilled when they gave us the heads up, because we could have gotten zero actually, but they upped the game for us. And we're really excited about that. Maura Sullivan and I and the team here about doing some good work. And of course, we're going to be informed by the project we're going to be hearing about as well. So that's very exciting for us, that we'll be hearing things in this state with a national project around COVID that's going to make a difference, I believe, in the long run here. Retainer funding, it is a crisis right now in day and employment services. I just got statistics over the weekend for 8 organizations, and there are numbers, just to give you a flavor, 1.7 times revenue are what we're seeing for expenses in some cases. One outlier out of 7 broke even in their costs between July and August. That agency is an outlier. Everyone else lost money in July, lost money significantly in August. Again, and let me put it another way, and I'm trying to avoid saying dollars, because for a smaller agency, losing $60,000 is bad. For a larger agency, losing $290,000. And that's the kind of numbers we're seeing. And there are numbers, one of the CEOs called me on Friday, he said to me, you know, if this doesn't change, if this trend doesn't change, maybe we'll last till late winter. And that's all depending upon how much we cut administrative salaries. You know, do we cut them 50%, 30%? Do we, you know, we've laid off some people, you know, they have leases, all kinds of things. So we're going to be revving up for this over the next couple of days with social media, as well as communication with the administration. Of course, assistance for individuals and families home continues to be an issue. Further financial support for day services and residents that's going on right now as we speak. Special education issues, PPE to get local outlets going for people that can't afford to buy their own PPE and have in-home care going on. And we need to get our constituents prioritized for vaccine. And then some exciting news on Friday. There are rumblings in DC that the House is negotiating with the administration. So what's happened over the past few weeks, you might have heard that Speaker Pelosi negotiated with Treasury Secretary Mnuchin to keep the government going past December. That's in the press. We knew about that over a week ago, that was going on. Now, the most recent heads up, and we can't count on it. I just want to be really clear. These are rumblings. There's talks going on. It appears the Senate is letting the administration negotiate with a Democratic-controlled House. So this is something wait and see. So we're hoping it's a positive news. The rumbling was to the extent of even hearing a figure, and the figure, though less than the House's figure, is significantly larger. It's let's say 4.5 times larger than the last proposal by Senator Mitch McConnell. So it's significant. It's not small, but I don't want to even jinx the number because they're rumblings, and most of it's off the record. So fingers crossed that something will happen. We're hopeful, as one of my colleagues in Washington just said to me this morning, hey, we've got a hopeful week this week on the federal level. So let's not only hope, let's hope it becomes a reality. Let's pray that it becomes a reality because the states are in trouble. And if the states are in trouble, we're in trouble, and the people we care about are in trouble. Well, I'm excited to introduce a colleague and friend, Bruce Bird, Dr. Bird. He got his PhD from the University of Houston, which, by the way, I didn't realize. I always tie you into Kennedy Krieger and Johns Hopkins in my head. And he's a New Orleans guy, which is really, you can tell from his accent, by the way, still has it. He has a great reputation in the field. He's a policy guy, and that's probably why we get along so well. He's had a number of senior administrative roles, Catholic Charities, along with other groups, a national for-profit neurorehabilitation company in the late 80s, and of course, Kennedy Krieger Institute at Johns Hopkins. Prior to joining Vinfen, Bruce served for 8 years. I can't believe it's that long, right? Because it feels like you've been here forever. CEO at the North Suffolk Mental Health, a well-respected large community behavioral health center with strong affiliations with MGH, Mass General Hospital. And so he has been the head of CEO since 2009 and president since 2011, or vice versa. But I know it's been pretty over a decade, and he's somebody who cares. He's somebody who's committed, and really appreciate his participation today. And this is pretty exciting. Do you want to? I got some bullets up there about it, carefully, from your paperwork, but it's not necessarily the best way to present it. But do you want to? You want me to go through the bullets first, Bruce, or do you want to? No. Why don't you? Let's talk about it first, what it is, because I think we don't have to. The initials are about. It's a contract. It's a grant to Mass General, but you were very involved, right, in working with them and figuring out the strategy. And let's talk. Let's have you take over and share a little bit, and then we'll go back and forth with a dialogue.
All right. Thank you, Leo. Can you hear me okay?
Mm-hmm.
Great.
Sound great.
And before we get started, for everybody in the phone, I've been working with Leo for about 20 years, I think, and just have an enormous amount of respect and regard for Leo. And we've played a lot of regular baseball and inside baseball, and we appreciate all of the advocacy that you've been able to bring to the table, especially in the last year. And it's still needed, as you were just going through. We're one of those organizations right now that are going to try to hold our 10-day programs open, but we're not sure how long we can do that, because on $13.5 million in revenue, we'll lose about $6 million this year if things don't get fixed. And even for a large organization like us, that is going to be a big problem if we get into the spring and we don't have solutions. So appreciate everything you're doing for that. So on the PCORI contract, it is a very exciting award. It's an enormous project. And PCORI, for those of you who don't know the organization, it's the Patient-Centered Outcome Research Institute. It's a nonprofit that was funded by Congress somewhere in the mid-teens, I think 2014. And it's designed to take money from the Congress and push it out to organizations that have the capacity to really try to implement changes that will change practice and improve outcomes over a broad range of health problems. So we've been involved in another PCORI grant with Mass General that just ended on smoking cessation with serious mental illness that had really good results in a very large population in Massachusetts. But this grant is about what we can do to mitigate the effects of COVID-19 in congregate care settings. And we got into this because the head of the Mongan Institute right now, Steve Martells, is a psychiatrist and a gerontologist who moved to MGH from Dartmouth. He was there for many years, and we've been doing research with Steve and his group for about 20 years on a variety of problems in mental illness, in serious medical problems. So he's a real expert in comorbid medical conditions and problems in seriously mentally ill. But at the Mongan Institute, he's in the Institute of Medicine and has a much broader agenda than just seriously mentally ill. We've been talking to Steve for a long time, and when the PCORI grant came up, he said, this is an opportunity to do what you say you've been needing, and that is to really validate and improve client services and safety procedures in your programs, and let's look at this. So we started looking at this way back in May. The co-principal investigator, some of you may know, his name is Dr. Brian Scutko. He is an MD at MGH, and I know he's worked with Leo. He's very tied into the Down Syndrome Congress. He's been on the board. He's head of the Down Syndrome program at Mass General and has been published widely, spoken widely, and is a huge advocate in the Down Syndrome community. So,
and let me add, for us overall, he's been responsive throughout the years. So I just wanted to add that. Thanks for, that intro on Brian.
And my role has been to work to coordinate the community partners that are going to come along in this grant, and also the advocacy groups that we're going to deal with. So what is this about? It's about trying to evaluate the best practices that are available now and what they've done to mitigate the impact of COVID-19 in congregate care settings. And we are going to evaluate practices as they've been going on in 400 congregate care homes, wow, both funded by DMH and DDS. And Vinfen will be the lead in the community organizations, but along with us, we will have advocates, Bay Cove, North Suffolk Mental Health, Open Sky, and Riverside. We had planned on taking a few more, but it was a very large population, and we prioritized organizations that we know have really solid reputations for delivering services, but also who were in areas where there was relatively high incidence. So Vinfen, for example, we operate 163 residences between the DDS services and DMH services. And we're in a lot of the high incidence areas. So we're in Lowell, Lawrence, parts of Boston, parts of Cambridge and Somerville, where incidences in the general population have been high. So our incidences in clients have been over 200 positive cases, and our incidences in staff have been just under 200 cases to this point. And so we've been in the hot spots along with some of our colleagues, especially Bay Cove and North Suffolk. North Suffolk's been in Chelsea, which has really been hot, unfortunately. So the aims of this study, oh, by the way, we have a number of advocacy organizations that will be involved also. The advocacy organizations include the ARC of Mass, Mass Advocates Standing Strong, Massachusetts Association of Mental Health, NAMI Mass, and the Mass Down Syndrome Association. And those advocacy organizations will provide feedback. Once we get what we think are best practices identified, we'll actually bring in stakeholders from the client viewpoint, the family viewpoint, and staff viewpoints to critique and give us their best information as to whether or not they think these systems are going to be improved. And that's what the aims of this is all about. It recognizes that people in congregate care settings often have significantly higher risk for poor outcomes in the medical health arena. They've got cardiovascular disease, diabetes, other chronic conditions. And we have the same kind of risk of residential transmission, only much lower volume of that than in the nursing homes. But we do have the risk of having multiple clients impacted in a facility, a group home. So we have a lot to worry about in this. And some people might say, well, it looks like we're going to have vaccines maybe, and this isn't going to be a continued problem. But the people we're talking to, one of the people on the grant is a wonderful internal medicine specialist at MGH named Julie Levinson, who's worked on one of Fauci's committee for Latinos. And they're predicting that this is going to, unfortunately, really drag on into the spring and maybe longer, even though vaccines are out, because people are going to be resistant to vaccines. And that's a whole nother topic, which I'll come back to in a minute. So this is going to be around for a while. The goals of the research are to try to figure out what have been the most effective and best practices to prevent the spread of COVID-19, to keep them out of the group homes or to keep them contained in the group homes for people with mental illness and developmental disabilities. And then once those best practices are identified, what's the best way for us to tailor them to make sure they're being implemented well in the group homes? And then beyond that, to write this up to disseminate around the country, because we hope we will, but we probably won't be through COVID when we get through at least the initial study in this. And then it's also going to have practices which could be applicable to other kinds of outbreaks of infectious diseases. So there's a great team of people at Mass General that Steve and Brian have brought us to, including some really competent statisticians that know how to look at simulation models to say, what are the real levers that seem to work to contain the virus in other settings. So they're about to publish a big study on the impact of COVID-19 and mitigation practices in universities. Wow. Kind of timely. And they were also the ones that did the initial projections of how to mitigate and contain this in the homeless population. So that's a very complex statistical model, but we'll be spending a few months trying to get information together to them on the data that we have all had in our organizations and what that means. They'll run simulation models, and in the meantime, we're going to start to try to figure out with the infectious disease specialists on the team at MGA, what are the best practices and what are the ways we need to change those practices to make sure that we're going to mitigate COVID-19 is if we get another surge. And the practices basically are the things that you know about. How are we doing in screening? How are we doing in using PPE in practices related to PPE? What are we doing for isolation and how is that working? And what are we doing in contact tracing? Those are the main things that we've all learned to try to adopt in the COVID-19 pandemic so far. And actually, the CEOs in the group we brought together, we've been trying to share information as we go. So if you ask me right now, is our practice generally better than it was in March? Absolutely, when this first started. Vinfen has spent $1.2 million in PPE purchases. We didn't have all the PPE we needed when this first started to break, and we know it. But we have it now, and we know we've gone through 2 rounds of training on our staff. Are they really using it as well as they should? Well, we need to really make sure we got some better fidelity audit processes to make sure that that's happening. And so all of these practices that we're doing, we think need to be evaluated, and if they aren't quite what we need them to be, they need to be improved and then redistributed out there to try to make this happen. The other thing that the PCORI funders have recognized is, as we are beginning to hear about vaccines that may be ready, we're already hearing about rumblings in families and staff about whether or not they're going to want to take vaccines. So if vaccines come out in the middle of all this, let's say in the winter or spring, we've already talked to PCORI about the possibility that we can pivot and start to look at ways to make sure that we can educate people and engage them so that they will accept vaccines. We thought we were going to have that problem with testing, and we're still having a little bit of it in our clients, but in staff, you probably are well aware of this, Leo. Thanks to a lot of advocacy by the ARC and others, the state is now paying for us to do testing of our congregate care staff, and we believe we will have tested all 1,800 of the congregate care staff we have by September the 30th.
Excellent.
And then we'll be on a cycle of retesting them every 2 weeks if they're in a high incidence area or whenever a trigger occurs, like a positive client. So that's sort of the thrust of the study. Once we get better practices proven by the data we're collecting and the research design, we'll then package that up and roll it out, not only across Massachusetts, but across the US. And I think I'll stop there. That's
great. Yeah, go ahead.
No, I mentioned the stakeholders, so
yeah,
I think I'll stop. How's that?
Great introduction. I want to talk a little bit. Let's just mention the testing. I'm glad you brought that up because actually it seemed like a debate for a while, right? I remember families reaching out to me and saying, I'm being told staff are refusing to get tested. And I thought that was odd, okay? But we all know in our field, right? There's some debate about surveillance testing versus, we all agree with on-demand testing. I mean, you know, that means if you suspect something, you need to have testing right away. Doesn't take a nuclear scientist to agree on that, right? But the surveillance testing, you and I we were on the phone one day and we were surprised that some colleagues were objecting to that. And I think, my feeling, and I don't want to speak for you, was, well, how do you know? the person's asymptomatic, how would you ever know, right?
And we had a number of those kind of incidences occur in our homes where somebody was asymptomatic and then the next day they were, but by the time they were tested and moved out of the home, we had clients and staff infected. So yeah, I think all of the CEOs in our group are very supportive of doing as much testing as we can. There were a couple of colleagues who were questioning that whether this should be mandated or not. And I believe that has been removed at this point in time.
Right.
But I know organizations like Vinfen and Bakehover are going to say to staff, if you haven't been tested, you cannot come in and work because there's a danger you could bring something in. And it's still, you know, there are still possibilities that the infection could sneak in. So it's a concerning time. We just had a mini outbreak in Connecticut where we had a home with a client. It was an IDD home. One of the client's boyfriend got COVID. We didn't know it. The client was asymptomatic, became symptomatic. And by the time we tested everybody, we had all 3 clients in the home symptomatic. So
Wow.
we have to be really vigilant. We have to keep up our practices and because this is by no means over yet.
Right. Let's back to, there is a question before I ask you, I was going to ask you a contrast question, but before I do that, Christine's asking, what about testing for day programs? And I know one of the things I hear about a lot is the funding of that, right? That's been a barrier. And now we have 12 feet distance between people, which honestly, the staff can't be 12 feet away. So that's not realistic, right? So, and it's probably not realistic financially to keep the 12 feet regulation, you know, long-term, right? Because of what we're experiencing financially and the state's inability to respond fiscally to the extent they would need to. But the testing for date, where do you think that's at? And I assume it's more at on demand, right, situation?
Right. If we have a positive symptomatic indication or a positive test, we're going to end up testing the whole day center. We had to do that in Connecticut, by the way. And thank God we didn't really have problems, but we're continuing to push for that. And we're going to do some testing in the day service programs. We don't know how much right now. It's how much can we afford. It's expensive. The tests are typically running about $120 a pop, and that's a lot.
Right. Well, one experience a colleague of ours had, he was able to get some people into a mobile situation or a tent situation where they were there for residential, and he encouraged the staff at the day services to go there. But that's unique, right? That's really a one-off, and it doesn't solve the problem that Christine's asking about in terms of surveillance testing.
Yeah, you know, our direct care staff often work 2 jobs and they are extremely busy. And so we've adopted a saliva test that was developed at Rutgers, which is easy for staff to self-administer. And we can just have supplies at the home where they can actually do it there and it can be shipped out. And we've been getting return reports in about 48 hours, which is pretty good. And when we first got into this with Fallon and some of the testing, even though they were doing as best as they could, we weren't hearing results for a week. Right. And that's a long time to go without knowing what's happening.
I'm curious about the contrast with DMH funded programs versus DDS funded programs. Your experience, is some of that related to people at the DMH programs possibly getting paid more, not having as many jobs? What was, because I think the incidence was lower based on the dashboard.
The incidence was a little lower in the DMH programs. And I have a hard time understanding that, Leo. We have a lot more problems with client adherence to guidelines in the DMH program. So we've had programs where clients have said, no, thank you, I'm going out, and come back in with no mask or don't want to wear a mask in the programs. And staff do the best they can with trying to encourage and support people so that they will adhere. But it may just be the luck of the draw in terms of where the populations are that come into work in our programs or where clients have gone in and out.
Do you think the staff, I'm just curious about the direct support professionals, do you think they're paid? I think they're paid more, correct? In DMH too? Maybe they're working less double jobs, or no? Is that not true?
They're paid a little bit more, but not much. And with the adult long-term residential rate increases that we're supposed to get July 1, we will raise all of our DD staff to the same level. So.
Oh, wow, it's that close. Wow, okay.
And we're looking forward
to it. I know, but that's for all of them. That's I didn't realize that. Wow. Unbelievable. as we look to the vaccine, let's talk a little bit about that and people's resistance. Are you thinking it's going to reflect some of the resistance initially that we had with testing or not?
Yeah, I do. And so providers are already starting to talk about what do we do if we're running a group home and the vaccine is out and well documented and we have staff say, I don't want to take it. What are we going to do about that? We encourage staff to take the flu shots. We don't mandate that a staff cannot work if they don't take the flu shot. But we are really concerned, especially about our vulnerable populations. And for the COVID-19, we and a number of providers, Bay Cove, Riverside, are saying, if you don't get tested, you cannot work. We're not going to put you on the schedule. So we're taking a very hard line on that because we do not want to have people bringing that into the congregate settings.
Wow.
But for vaccines, we're not there yet. We're starting to have those debates. But I have had staff in our own central office say to me, with all this politicization of things, I'm not sure I'm going to trust when vaccines first come out. And what is it going to take to get them over the goal line to actually accept a vaccine? That's something we're talking about already.
Wow. You mentioned the fidelity, in other words, how well do staff really follow through with instructions around cleaning their hands or wearing masks? And we take for granted, I don't know about you, I was getting a cup of coffee one day a few weeks ago, and I had to tell the young man pouring my Dunkin' Donuts, and I'm not trying to advertise, I drink Starbucks too, and I like Pete's too, so they're all good. So I just had to tell him, hey, your mask is below your nose, bro. Could you please do something about that? And, he's pouring me my coffee, right, as we speak. Now, an epidemiologist said, no, you can eat food, I guess. You're not going to get burned. I don't know about liquids, but so you have that issue, right? That's a given. What are other issues you think early on?
Well, and let me just tell you, our program directors are looking for adherence when they're in the residences, which is a lot. And our nurses zoom in periodically and say, show me around. Let me just take a look around the residence with them, with an iPad camera or something, so they could spot check. But we could probably do better in checking for fidelity, because if you're out in the general community, like I am, you see people who are experiencing mask fatigue, right? Walking around with their mask down here, up here. I just did a video blast of the whole company a week ago, reminding them to stay vigilant on all this. But we need more fidelity testing, and we need to make sure we're adhering to those practices.
One of the things Lucy asked is probably not super germane, though it's a great topic for a future session. One of the questions was the whole issue when individuals can't wear a mask and the challenges that poses for staff in doctors' offices, or are there issues? Are people being prevented? Have you heard, or is it people are just accepting it?
No, we have clients who, just don't seem to be able to tolerate a mask. And we have a great group of clinical behavioral people working with clients to try to reinforce mask adherence and all of that. But we have quite a few who have a real problem with that. And, I've had program managers say, so we've got 4 people with intellectual disabilities in this home, and they're in their own home. Do they have to wear a mask all the time in their own home, or if we separated them? And so there's a lot of discussion, and there's probably a lot of give and take going on out there in the residences about what's really happening. That's another thing we want to really try to identify, but I can understand that.
Yeah. So one of the things you're telling me really is sometimes it's a need for dialogue off and on intermittently, not to tell people what to do necessarily, but to talk about it, to talk about maybe the fatigue, to talk about, the not necessarily anxiety, but the drudgery of it, right? The maybe it's a reminder of what they don't want to be reminded of. Is that fair?
Well, yeah. I mean, you've been in group homes, and in my early career, I spent a lot of time working out in group homes and behavioral training and doing restraints and things like that. So I understand how complex and challenging those environments can be at times. And I think our staff have done a really, really good job of following the practices we have, but we think we could probably do better. So
what are other things? Do you think, for example, nurses' ability to react to the virus, because they weren't hired to, do that job. They were hired to do a different job in community nursing, correct? So were there other things early on besides the issue of how well staff managed their own healthcare and relationships with folks they worked with that you think early on you recognize, or is that PCORI is going to help, the contract's going to help maybe weed some of that out, tease some of that out?
No, I don't know. I haven't thought about that as much. We have a really great group of nurses. We've had, our director of nurse and our associate director of nursing has been around a long time, and they've worked in these kind of programs. So they understand the infectious disease stuff pretty well. And we've had a number of consults in also, but I don't know.
Okay.
How to answer that.
Just curious, because there's so much happening early on, right? Being thrown at you, both your teams and yourself, to get a hold on this. And we were being told different things all the time, right, about the infection for the first month.
We have, most of our colleagues, as we do, we have an infectious disease control committee, and our medical director does a lot of policy work with the hospital association. And so we were able to bring some infectious disease specialists in. We actually, the group that is of CEOs, we called on Scott Bach, who got Barry Bach, his brother, from Healthcare for the Homeless, to bring in a senior infectious disease person from Boston Medical Center. This was like in June, to give us some do's and don'ts and tips. And so we've been trying to piece together the information as well as we can and adapt it and then disseminate it.
And your former medical director is at Blue Cross, because he almost was giving us, we had an epidemiologist, touch base with the chapters, Bruce, and it was almost him, so, and so that's pretty cool, all the different people. And I didn't realize Barry was Scott's brother. So that's news for me. I have a question again from Lucy, which, and this might be something you're going to learn about, and just question about the after effects of people having the virus who recovered. And rashes, different,
I wouldn't consider myself at all an expert in that. I know we've had cases of staff who were out of work for several months after they contracted and recovered from COVID-19 because they had lung problems afterwards. And in the medically vulnerable population, I don't think I have a handle on that. I don't have any data to report on that, but that's something we're all concerned about.
My hunch,
really good question.
My hunch is your committees would have reported anything extreme, trends. So if there is something, it sounds like, but it's something for us to follow up on. Lucy's question is a great one, and I think it'd be a great one, not only for your project, but for me to be asking other organizations about and DDS about. I'm trying to, anything else anybody wants to ask? We're like 10 minutes away from 12:45, so I want to make sure if there's anybody. I know there was an early question from Mike Maloney about the deaths, and Mike, I'm gonna have to pull open, as soon as I stop sharing this, I have to pull open the internet and give you, I think the dates, the last number you and I had, we talked about a few weeks ago. I don't think it's going to be considerably above that, given the fact that I don't have data for last week. I only have data through December 16th. So, and there were no deaths reported on the last data sheet I looked at. And as you know, they're not accumulating it anymore, which is too bad, because that means we have to add numbers or phone someone to find out what that number has gone to. But it was over 100. And Mike, you might remember better than me at the last time we talked. I don't know if it was 109 or something like that. If you want to jump in and mention the number, that's fine.
Is that Mike out there?
110. He just shot it in through the chat. 110 the last time we checked. And I think he beat me to it. I think I was guessing 107, and he got the hard number, which was 110. And again, the last chart I looked at, it was 0. There he is, upside down on us. Are you doing exercise?
Whoa.
He is. He's upside.
I'm doing a headstand.
Time. Okay, Lucy, that's one of the after effects of COVID, and I couldn't get about it. Reinfection. Randy's asking a great question. If there's been reinfection issues, you would have heard about that, I would think.
Not that we know of. I think we would have heard about it, but not that we know of.
But I wonder if NGH is going to look at that with your partners. You're going to be 400 people, right?
I'm sure they will.
Yeah, that will be a great thing to assess, because we are worried. We heard about one so far. I mean, I don't know, maybe we've heard about more than one, but it's 110 deaths. I just want to go back to that, why again this project's so important, 110 people. Now, I know some of those people that passed away, I'm assuming, were people that were in terminal conditions, because I have a couple of people that a colleague told me about that I knew. By the way, I used to run residences and oversee them. It was really satisfying part of my life, building, opening new homes and challenging the community to connect and social inclusion and all of that. It was a different time. All my staff, had college degrees. It was a very different time, and we're well trained. And I think today we have a lot of well-trained staff. So please, people, don't quote me as saying that's different, because you have to have well-trained staff with the regulations in place. And but 110 people, even though it tracks with the general population, I would say the number's not excessive based on reality. But we lost some younger people, right, because of their conditions, other conditions.
Hey, Bruce, this is Mike. Collecting data from 400 congregate homes is a heavy lift. How is the project organized among a handful of agencies? That's pretty impressive.
Well, each of the agencies is going to have somebody who's going to be a
Leo.
Each of the organizations will have somebody that would be a paid project manager, and they'll also have some funding for data collection. But it's not as bad as we thought it was going to be when we first started out, but it's going to be a big challenge. So we've got a couple of people on Vinfen's payroll who will be helping to coordinate this. And then we'll also be helping to have coaches go out and work with trainers in various organizations if there are targeted best practices which improve what we're doing now, to hopefully improve the implementation of whatever we learn in this. But the data collection is a heavy list, no question.
So one of the exciting things, Bruce, of course, is that consortium that HMEA is organized right across the state too, and they have about 12,000 lives. But that would be, I can't even imagine tracking that number. But it's, again, something to think about, right? As you develop some things, it might be a great project for the consortium as well, right? To take on. But 400 is a daunting task, but it's going to be great to have that information. Any last questions? Because I want to keep us on time and also talk about what's coming up this week. This is really informative. I know we have a bunch of folks that are either agency leads or self-advocate leaders and family leaders. So last chance for one more question. Now, I do want to say, while we're waiting on that, I just want to say a blessed Yom Kippur for those of you, if you happen to be on, and I think it's okay if you're passively on the internet. I know I grew up in New York City with close friends who were the Jewish faith, and I remember the rules. And I think, is it Yov Tom? Okay, I'm probably going to say it wrong. I had written it down, but in Hebrew, have a blessed holiday. So I want to just say that. I didn't say that at the break of the session. And it looks like there's no more questions. So what I'm also going to do, I'm going to surprise Bruce. And I put this up on the screen that everybody will get. It's promoting, isn't that something? That's a picture of Bruce is actually in that picture. All right, with the Family Council at Vinfen. And they're going to be doing a virtual program over 3 nights at 6 p.m. But mind you, they're not all night. They're like anywhere from 10 minutes to 25 minutes.
Can you share?
Well, I will, Jared.
Send to me the link.
You will get it later today. I'm going to ask Katerina because Carrie will do it later this afternoon.
Who? Carrie Ann? Who?
You'll get it. Jared, I promise you'll get it. And I don't have any edits to do today, thank goodness. So I have
Carrie or who?
Katerina, but you'll get it, buddy. And you'll get to hear the whole thing.
Where's Carrie Anna?
Well, she's tied up today, Carrie. So, but anyway, hold off, okay? So I can finish this announcement. So when people see the recording, they'll get to hear it. And bottom line, it's going to be a great event. And I think, again, Emily Pearl Kingsley, who's a Sesame Street alumnus, is recorded on it. Susan Warnick is your host again. And you've got a wonderful artist, Ruby Pearl, who I guess there's going to be snippets of her over time doing this artwork that's dedicated to the people of COVID-19 who passed away, if my memory is right, and who suffered from COVID. So it's going to be pretty moving. And actually, Lucy and others have been regular attendees because I would get to run into her at those. So it should be a great event. And I also want to remind people that your support helps make a difference for us. And I also, Maura Sullivan is off this week on Thursday, but tomorrow there's a check-in with Kerry Mahoney. And want everybody to have a great week. And Bruce, I can't thank you enough.
When is Thursday meeting?
Thursday's not happening. Tuesday, tomorrow at 11, Jarrett. Okay, and then this Thursday, no webinar. Next week, Maura will be back. Okay, and Bruce.
Thank you, Leo, for all your advocacy you're doing. Pleasure to be with you as always.
And same here. Thanks a lot, everybody. Take care. See you soon. See you around the corner. Bye-bye. Got to find the end meeting thing.